Okay, and good morning and welcome to the Davies Use Case webinar being presented by Banner Health and on virtual care on increasing capacity to deliver high reliable care. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes the outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award's winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar, Dr. Michael Simons from Banner Health. Dr. Simon, I will turn the presentation over to you, and you can begin when you're ready.
Thank you, Arnold. My name is Michael Simons, and I'm presently the Medical Director for Virtual Care at Banner Health. I previously functioned in the leadership of the medical group as well as system critical care, and as such, I was involved in a number of strategic initiatives, including the sepsis strategic initiative, which is particularly important to this presentation. So it's a pleasure to speak with everyone today, and I look forward to sharing what we've learned at Banner. So a little bit of history about Banner Health. Banner Health formed in 1999 as a merger between Lutheran and Samaritan healthcare systems. Since that time, Banner has grown to include 28 acute care and critical access hospitals, a dedicated behavioral health hospital, contains health networks both in Arizona and Colorado, and operates medical groups both for our community operations as well as our university operations, which are comprised of approximately 2,000 physicians and advanced practice providers. Banner operates home care and hospice operations, as well multiple outpatient surgery centers and a large urgent care contingent. Banner collected $7.6 billion in revenue in 2016 and provided $753 million in community benefits, including $89 million in charity care in that same year. Our mission is to make healthcare easier so life can be better. We leverage the 4 pillars of our strategy in order to achieve that, including helping our customers to be their healthiest, growing our reach and impact, engaging and inspiring our people, and perfecting the customer experience. Banner also utilizes an operating model with an integrated governing process comprised of a single board of directors with centralized management and corporate functions. It is a clinical quality company which aims to enhance clinical quality while pursuing affordable cost models and maximizing the patient and member experience. Importantly, the single board of directors drives a common strategy throughout the organization and allows our IT leaders to tightly align their technology strategies with that overall strategy for Banner Health. So we're moving now into the main part of today's presentation, which is virtual care, and then moving into the sepsis/safe alert system. Virtual care aims to increase capacity to deliver highly reliable care. So we start with the local problem, and it probably isn't local. It actually was national at the time and to a degree still remains. This was identified between 2004 and 2006, And the question was, how does Banner Health improve care outcomes by providing highly reliable care while increasing the capacity to deliver that care? And this is highlighted by the critical care environment at that time. It was recognized in the early 2000s that by 2029 we would have an extremely large increase in the number of elderly population with multiple comorbidities for which our healthcare system would need to care. There was also the recognition that our healthcare system in the United States was fraught with medical errors, with 1/3 of all hospitalized patients experiencing harm during their stay and more than 400,000 preventable hospital deaths occurring. There were physician shortages in multiple areas, in virtually all areas, and particularly important for this discussion in the area of critical care. And this occurred in the context of recommendations from national luminary bodies, including the Leapfrog Group, most importantly, who were advocating for more consistent and dedicated staffing of critical care patients by trained critical care providers for all of our ICUs around the country. At the time, there was the common practice pattern for the critical care docs around the country, and certainly within the Banner Health operations, were pulmonary critical care private groups who undertook the traditional private practice approach at the time, which was rounding on patients in the critical care environment, rounding on patients on the floors and from a pulmonary perspective, and then conducting outpatient clinic obligations to their patients at the same time. So we had 3 different obligations that were from these providers who were ideally being dedicated to the critical care population, but that wasn't really feasible in that environment. As well, there was significant shortage of trained critical care docs coming out, certainly in the Arizona market where there's relatively few training programs, but also nationally. So how do we design the standards for care, and then how did that play out into the critical care environment within Banner? The governance for care in any given clinical discipline is provided by what are called clinical consensus groups. Clinical consensus groups are those entities which serve as a repository for clinical expertise in that area. And they are comprised of clinicians who practice in that environment, both employed and volunteer, as well as additional support personnel from program management, process engineering, informatics, quality, performance analytics, and clinical education. These groups assemble on a regular basis, determine what is appropriate for standardized care, for reduction of variability, and then how to operationalize that. These CCGs utilize a 3-component model to achieve the new designs that they deploy throughout the system. The 3 components are what are called define, design, and implement. The define component is firstly coming to agreement that the putative area is one that we feel care can be and should be standardized. We then research those clinical practices as well as the relevant literature from around the world as well as the nation to determine what is that best standard. We then codify that into a document that is called a clinical practice, and we vet that clinical practice, that codified statement of the standard of care with the relevant CCG. If that is approved, we move into a designed process where we develop all of the tools and education necessary to deploy this throughout the system and to make it easier to achieve the intended workflows. We then implement this at all of our operations around the organization, ideally at the same time, with education to enable this to be successfully done, as well as monitoring to ensure if there are new developments or opportunities that are identified post-implementation, that we can then either redesign and adapt our tools or our education to address whatever that deficiency is, or potentially a redefine, go back and now define the clinical practice differently, then process again through the design and implementation phases. This is an ongoing iterative process that is meant to provide a living process for improving the care in the selected area or clinical entity throughout the lifespan of that particular clinical practice. So that brings us to telemedicine, which was the solution that Banner decided to undertake to address the increasing acuity of patients in our critical care environment, as well as the need for greater staffing. So leveraging technology to allow a given critical care doc to care for more patients than they would typically be able to if they were functioning in a bedside capacity. It's important to note that telemedicine is more than technology. It's often technology that people focus on, but it's really, technology may be the easiest part of the three-piece puzzle that is necessary to solve. Firstly, you need the right people. You need a highly leveraged, centralized care team that is aligned with the mission of that particular project, as well are trained in the tools to be able to perform it in the way that we need and to work with the technology that is identified to help them. You need processes that can help drive that improved quality of care over a larger population of patients, and then you need the technology which enables the people to undertake those processes. In the tele-ICU, which was the first program that Banner developed in telemedicine, we have 5 core missions. Firstly, to identify adverse trends and intervene before those adverse trends become adverse outcomes. This utilizes the population health tools that are embedded within the technology that is deployed to our teams. Secondly, and probably most importantly, to respond to requests for help from the bedside. As you'll see soon, there are a variety of mechanisms that communication can be established with the centralized team, including a way to immediately summon help if needed. Thirdly, to monitor and assist with best practice compliance and applicable system initiatives. There are a number of elements such as prophylactic measures, clinical practices that involve the reduction of healthcare-associated infections, for which the tele-ICU team continually monitors patients and intervenes if they find that they are deviating from those best practices. Fourthly, to measure performance across the system in a standardized and risk-adjusted methodology. This was one of the challenges in looking at outcomes in the critical care environments, both within our system and also around the country and the world, is that if all you have is raw mortality and raw length of stay, it is difficult to make any conclusions without very manual investigations on each of those elements, which are only applicable for that period of time. You really need a robust form of risk stratification that's applied to performance so that you know, is it because the patients are sicker at X facility versus Y, or is it because the care is truly less robust than it is? And so we have used patchy risk stratification throughout our tele-ICU program since its inception. And then lastly, to utilize real-time data to drive performance improvement, and we'll see an example of that later in the presentation. So what does the technology look like in the tele-ICU? You can see a number of the components here. In the upper left-hand portion of the screen, you can see the camera, which can be controlled by the clinician in the centralized operations center. As well, you see a screen which displays that clinician in our centralized operations to the bedside care team or to the patient or family with whom the communication is being undertaken. You can also see below that and what's called the eAlert button, which is a button that can be pressed to immediately summon the centralized team to that room for a patient emergency. In the middle, you can see a Voicera, which is a communication device where you can communicate somewhat like a walkie-talkie, and it allows our centralized operations team to communicate immediately with the bedside team if necessary. And then to the far right of your screen, you can see one of our providers operating in our centralized operations center with the number of monitors arrayed before them, providing pop health information as well as patient-specific information, and enabled with the video conferencing tool that you can see displayed in the lower center screen where they're viewing the patient. This is a screenshot of the patient-specific information in that Pop Health Tele ICU software, and it provides a large amount of information within a confined geographic space to quickly give our clinicians working in our centralized teams a snapshot of what the patient is experiencing and what their status is. There's relative acuity assessments, which is in the upper left-hand corner of your screen. There are a narrative that is entered when the patient enters into the unit by the critical care nurses who work in our centralized operations center, which is updated with any new information. There is vital sign data as well as laboratory data, and then in the center you can see a number of annunciators which indicate abnormalities in the patient's vitals, labs, or other identified areas. You can see one there that says sepsis. So what are the keys to success in this manner of program? Culture is tremendously important. You're bringing a centralized team into an area where they are not accustomed to working with an off-site provider unless it's one that they already know. Working with our clinical consensus groups to establish those standards of care so that we are adhering in all ways to what has been agreed throughout the system. Providing educational materials to patients and families so that they understand what the technology is and how it is helpful for them. Providing two-way audio, video, and monitored rooms so that the patients and the care team at the bedside can see who is providing the care. That tremendously helps with the level of trust and engagement from the bedside to the central teams. And arranging visits to the Tele-ICU Operations Center for the bedside care teams all are different avenues that we've gone down to ensure that there is a collaborative and maximally effective culture between our centralized teams and our bedside. The second key is procedures. We recognize that bedside intensivists perform a number of procedures that they would be unable to provide when our tele-intensivists are managing patients, which is limited, of course, to clinical cognitive response. So we needed to arrange for manner to accomplish those procedures in a effective, efficient, and timely manner for those patients while those bedside intensivists were away. And the three procedures that were most problematic or needed to be addressed most acutely were endotracheal intubation, central line insertion, and thoracostomy tube insertion. So we've worked with our ED providers or in-house trauma surgeons and in-house trauma anesthesia to accomplish intubations or thoracostomy tube insertions. For central line insertions, we undertook a novel approach of training respiratory therapists to utilize ultrasound to insert internal jugular central venous catheters under ultrasound guidance. This, in our preliminary data, has proved to be very timely and much more consistent with the bundle and the insertion bundle, therefore driving better outcomes for our patients than we experienced even when physicians were placing these. Thirdly, you need some surrogate for physical exam because you cannot physically lay hands on the patient. How do you get the same information that an intensivist would at the bedside? All rooms are equipped with high-definition tele-intensivist controlled cameras. Very importantly, there is the ability to show all vital signs and waveforms in real time from the bedside in our centralized operations center. And then lastly, again, we leveraged our respiratory therapists and trained them to perform limited standardized cardiac ultrasound views, long axis, short axis, and subxiphoid views, which are interpreted in real time by our teleintensivist to get a gross sense of cardiac output and volume status to allow that information to be done in a very timely manner and to drive that initial care even before central lines could be inserted. And then lastly, how do you fund such an operation? We do not bill for any of the services directly to the patients or payers. It is funded by all the receiving facilities commensurate with the number of monitored beds with the expectation of cost avoidance savings from length of stay reduction. So currently we're deployed in more than 600 critical care beds in 5 of our 6 states, in 26 facilities with 47 discrete units. We are staffed with 1 teleintensivist during the daytime hours when we typically have bedside intensivist teams, and 5 teleintensivists and 2 acute care nurse practitioners every night when we don't have dedicated bedside teams. There are approximately 12 critical care RNs around the clock and 3 to 4 unit secretaries which help to triage communications also 24/7. Here you can see a timeline of telehealth operations within Banner, beginning in February 2006 with the first block of tele-ICU hospitals, which was 5. We've now expanded to 26 hospitals. In 2009, we expanded our telehealth operations outside critical care to the med-surg population, presently being deployed in 3 hospitals. We began blood transfusions, sepsis prompt, and DRS validation studies in 2010 through present, and we'll talk more about the sepsis iteration very shortly. We began an intensive ambulatory care operation in June of 2013, targeting complex chronic patients at home. E-SNP operations began in 2014, presently at 3 facilities, teleophthalmology in 2013, telebehavioral health in the EDs in 2015, and teledoc is our present direct-to-consumer implementation, which began with a partnership in 2018, also involving Banner Aetna, an insurance partnership that we have. So how do we derive value? Severity-adjusted outcomes, and here we can see severity-adjusted mortality. It's important to note when we look at this data that the most important of the 2 graphs, which are ICU mortality ratio on the top and hospital mortality ratio on the bottom, is the hospital mortality ratio. And somewhat counterintuitively, this is not the mortality for patients throughout the entirety of the hospital, but the mortality of those patients who pass through the ICU, whether they die in the ICU or they die outside the ICU on the floors after downgrade. That's important because if you look at solely ICU mortality ratio, that can be affected by triage practices. Let's say if a patient is expected to die and we are no longer escalating care, that patient in many circumstances may be moved to the floor because they no longer require the full armamentarium of services being provided in the ICU. That patient would be counted as a live patient if you solely looked at ICU mortality, while they're captured within the hospital mortality ratio in that graph. This is a ratio observed over expected, so the lower the better. You can see in our ICU mortality ratio, there was a significant increase that occurred in the 3rd quarter of 2015 with a shift of that line toward the expected line of 1. And that was related to challenges with a data transfer from our EMR into our telehealth / Apache 4A system, where there were changes in the GCS scoring. We did a deep investigation. It wasn't immediately apparent at the time that that's what had happened, but after a careful evaluation, we decided to leave the interface as is and not restore it to its prior functionality because we found that the new data was actually more reliable and consistent with the literature than the old data. You see a similar bump in the hospital mortality ratio, and that effect, of course, cascaded not only into the ICU, but also outside to the patient's subsequent stay in the hospital. Nonetheless, we've been able to achieve a fairly consistent now, approximately 0.8 ratio for the last 2 years compared to the expected mortality in our hospital mortality ratio. The next graph shows length of stay, and this is where much of the cost avoidance data is gleaned. The Glasgow-Coma scale, which is the area where we had the issue in the prior slide, has less effect on length of stay predictions for Apache than does mortality. So you don't see the dramatic effect in Q3 of 2015 on this graph. And as you can see, we've been able to achieve a low length of stay both in the ICU and in the hospital in general after the patients leave the ICU. That ratio has ranged around 0.70 for ICU, so 30% better than predicted, and about 0.75 for hospital length of stay. It's always important in looking at ICU length of stay metrics to include both the ICU and the hospital length of stay, because if you send people out of the ICU early, your ICU length of stay may be very favorable, but you may see extended stays in the hospital because of that early triage out of the ICU. And so looking at them in parallel and ensuring they're both going in the same direction is absolutely the way to give you the best picture of what's actually occurring. Here we look at the impact of two specific clinical practices and strategic initiatives and how they impacted our length of stay for critical care patients. Between 2012 and 2013, the system undertook, as part of what's called the Clinical Informatics for Process Improvement strategic initiative, targeted improvements in sepsis and delirium care. The delirium particularly targeting our ICU population. And concomitant with those practices and the tools that came with them, we saw an approximately 20-hour improvement in the ICU length of stay across the system. If you use as a context with that information, that would correlate to $22 million in savings based solely on the cost of an ICU bed in our system. So if we roll up the impact of our tele-ICU program from its foundation in 2016 to present, we find that based on observed versus expected, 15,297 fewer patients have died than Apache would predict. There have been 550,000 plus fewer hospital days and 297,000 plus fewer ICU days than Apache would predict. Those can be converted into financial savings depending on your payer contracts and your bed costs. So we'll now move into the area of sepsis and the Safe Alert. The sepsis initiative originated within Banner, sparked by the 100,000 Lives campaign and the surviving sepsis work of the Society for Critical Care Medicine. The processes were developed in 2010 to 2011, and after a trial of 6 months, work was continued in 2012 as part of the Clinical Informatics for Process Improvement strategic initiative. The sepsis component of that was comprised of 3 different elements: a severe sepsis and septic shock expected clinical practice, a real-time automated EMR-based screening system with alert notifications, and care sets, which were optimized in alignment with the clinical practice. Our metrics in 2012 included an outcome measure, severe sepsis housewide mortality, a process measure, severe sepsis or sepsis bundle compliance, and a context measure, which was failure in investigation as well as action based on the Just Culture algorithm. Here's an example of the title page from the clinical practice in question, Severe Sepsis and Septic Shock, which was authored by the Critical Care Clinical Consensus Group. This clinical practice contained requirements for sepsis resuscitation and management bundles, timelines for each expectation, and this practice has been revised over the years based on changes in our local experience and with the sepsis literature. The second component was an automated real-time EMR surveillance system. This was based on a combination of systemic inflammatory response syndrome criteria and acute organ dysfunction criteria. Timeframes were critical to ensure that this was captured in a manner that could drive actionable information to improve quality of care. In order to trigger an alert, 2 SIRS criteria had to be met within 6 hours of each other. The only exception to that was white blood cell-based variables, for which there was permitted 30 hours because they were typically done once a day. As well, an acute organ system dysfunction had to occur, and there was look-back logic as well as exclusions to avoid chronic organ dysfunction firing these. Then there needed to be a third element, which was a correlation between those 2 triggers. If the SIRS trigger fired because 2 criteria are met within 6 hours, and an acute OD trigger fired because an acute OD was identified, those 2 events had to be within 8 hours of each other for the actual pop-up to fire. And that correlating third event was used as the time 0 for calculating bundle compliance for our patients. Here is a screenshot of the numerous logic flows for the sepsis and shock logic that were used in the alert surveillance. So how were patients placed into the denominator? Well, there were 2 ways to place a patient tentatively in the denominator, and it's important that I say tentative. I'll follow that up later. One was the sepsis alert. If a patient triggered the sepsis alert through the EMR surveillance, in the inpatient, based in the methodology that I just explained, or in the ED, based on the same triggers. However, when the patient was placed in OBS or an inpatient status, the ED provider would also be asked, did this patient definitely or potentially have an infection that was driving these findings? If the ED provider stated yes, definitely or potentially, that patient was tentatively placed in the denominator. If the ED provider stated no, then the patient would be removed from the tentative denominator. However, surveillance would continue in the inpatient status and would again be placed in the denominator if criteria triggered the alert. The second way to place a patient in the tentative denominator was through the use of a sepsis care set. So if a given clinician was managing a patient per the sepsis and septic shock care set, that implied that they were treating that entity and they would be tentatively placed in the denominator. They would receive a pop-up attesting to that at the time of care set usage. There was an exclusion for patients with DNR/comfort care orders prior to or within 6.75 hours of the alert. It needed to be within our predefined bundle period. If it was later than that period, we did not want to exclude patients who potentially were treated with sepsis, deteriorated despite that treatment, and then later were transitioned to DNR/comfort care as they were actively dying from an unsuccessful sepsis treatment. So this was really only intended to identify those patients in whom care limitations might be in place that would prevent us from adhering to the sepsis bundle. Here are the workflows which were developed based upon the patient's location. To the left-hand side of the screen are the inpatient workflows, and to the right-hand side are the ED workflows, which were very similar aside from that attestation by the ED doc at the time of inpatient disposition. And here is a screenshot of the on-screen alerts which facilitated the expected management. On the left-hand side of the screen, you can see the RN provider notification screen. We realized very early that nurses were in the charts much more frequently than a given provider in a given patient. And if we sent alerts to physicians that only occurred when they entered a given patient's chart who had fired an alert, it may be 6, 8, 12, or 24 hours from the last time they were in the chart. And it was then impossible to derive the standards that we were expecting. However, nurses were very frequently in the charts performing a number of tasks, and so the alert fired a notification to the nurse. The nurse was then expected to notify the provider, and this was the form that was used to document that notification to the provider. The physician needed to be listed from the list of physicians who were had privileges in that facility. The notification status needed to be filled out as completed, with provider collaboration completed, and then there was a checkbox for any orders which were received, and one of those checkboxes needed to be filled out so that it wasn't overlooked. So the last order option, or the last checkbox option, is no orders received. There was also a statement of what caused the alert to trigger, so that could be used in the relay of information, as well in the lower right-hand corner of the screen, or the screenshot, you can see the bundle requirements were listed for additional information during that nurse-provider collaboration. On the upper left, or the upper right-hand side of your screen, you can see the CareSet inclusion notification, which fired to the ED or inpatient docs when they entered a sepsis CareSet and tentatively placed the patient in the denominator. You can then see below that the sepsis bundle requirements. This alert occurred to providers when they entered the chart within the bundle period. If elements of the sepsis resuscitation or management bundle were missing, it listed those elements that were missing. And then lastly, you can see in the lower right-hand area of the screen a lactic acid alert, which only fired to the provider if the lactic acid was greater than 4, and identified those advanced elements which were necessary by that elevated lactic acid level per the clinical practice. This is a photo of the CareSet that was deployed. It contained all of the elements to drive the standardized care of sepsis for our patients as defined by the clinical practice, and it included embedded elements for antibiotic choices, which were vetted by the critical care clinical consensus group with input from our infectious disease colleagues for each of the clinical entities which we could identify as a group that might be causing sepsis. So you can see there is one option that says line infection or unknown source. So if you didn't know which of the other categories it fell into, you were expected to pick that, which drove very broad coverage. So how did we lock patients into the denominator? I spent a lot of time talking about how patients were tentatively placed. How did we confirm their placement for analytics purposes? Early in 2012, in our first iteration of this, it was determined by physician attestation at the time of discharge. So you can see the form that fired at discharge. It asked the physician whether during the patient's hospital stay the patient was ever severely septic. If the provider clicked yes, the patient was locked into the denominator. If the provider clicked no, then it would open a mandated field asking for what caused this false firing in your opinion. This was used to drive process improvements in the surveillance system. If no response was provided by 7 days after discharge, the patient was defaulted into the denominator. Owing to challenges with robustly meaningful response of this form, we changed the process in late 2012 to move up the attestation closer to the time of alert firing. We moved it from discharge, which could be 2, 3, 5, 7 days after the alert fired, to 24 hours after the alert fired. The provider, if listed as admitting or attending, when they went into the chart 24 hours or more after the alert, would receive the similar pop-up stating greater than or equal to 24 hours ago, this patient was tentatively identified as severely septic. Based upon additional information, does the patient meet criteria for severe sepsis? Yes, no. If not, then an explanation why. If the physician attested yes, the patient was locked just as prior. If no, the patient was removed from the denominator and the alert screening system was paused for 24 hours, at which point the surveillance reinitiated. This allowed for a repeat firing if criteria were met again. Again, if the patient or if the provider failed to respond to the form by 7 days post-discharge, then the patient would be locked into the denominator as before. The last element of this strategic initiative was the context measure, which was a just culture failure review process. We developed 20 specific failure codes, which you can see listed on the right-hand side of the screen. And on the left-hand side of the screen, you can see the tool which dedicated and accountable people went into during the strategic initiative period to review all failures which were patient-specific and failure code-specific. Multiple failure codes could be listed if applicable. And they would work through a just culture algorithm to determine whether this was an issue of human error, at-risk or reckless behavior, and would enact coaching or education or consoling the employee based upon those findings. So how did we do in our first year of the strategic initiative? And this is data from one of our facilities, one of our largest community hospitals. We achieved our sepsis mortality target. As you can see, the mortality target was somewhat lower than the published literature, and part of that is because we cast a very wide net with this process. It is really a surveillance system to identify at-risk patients and try to confirm that those are the right patients at discharge or 24 hours later, depending on which time period we're looking at. It was not a specific sepsis quality improvement effort where we were rigidly trying to define sepsis and only would identify sepsis patients. So we understood that the denominator could be slightly watered down. Sepsis bundle compliant, you can see gradually improved over the course of the strategic initiative period and ultimately met target in this particular facility. And the sepsis context measure, which is that just failure investigation where there was an 80% target, was met as well. That could be the end of the story. However, to my mind, a true measure of industry leadership is not in achieving a transient metrical success, regardless of how profound, but in the development and cultivation of those institutions which permit continued and ongoing progress. So what changes have we made since the end of 2012 in the sepsis surveillance system? Well, we changed our denominator determination from any version of attestation to post-discharge coding per the Angus criteria, which is a well-known tactic within the literature to identify sepsis populations. It also removed any variability in the adherence to the intended process that occurred from facility to facility. We changed the advanced bundle elements permitting point-of-care cardiac ultrasound for assessment of volume status. We removed the requirement for measurement of central venous O2 saturation. We changed our volume resuscitative approach commensurate with the literature, and we developed a methodology to temporarily suppress alerts based on specific care set utilization for those patients who frequently fired false positives. And this was our post-surgical population, for which there was a brief suspension, and our post-cardiac surgery population, for which there was a larger suppression time frame. Additionally, trauma ICU patients were also suppressed for a short period of time. The most significant change was the automation of lactic acid measurement, which occurred on alert triggering. During our strategic initiative period and even beyond that, our most common failing in the bundle was the measurement of lactic acid. After several educational attempts to shore that up, we undertook an approach to automate firing based on the sepsis alert triggering. And this was worked through both the critical care CCG and vetted by them, as well as by the medical staffs of all of our facilities to enable this to happen. We also developed a custom M page in late 2012. This allowed for centralized surveillance of the sepsis performance at a given facility or even system-wide. So as you can see, and I've removed the protected health information, which are the blue boxes that you can see all the patients who have triggered an alert, in this case from one of our facilities. This could be sorted to include all patients throughout the system or any facility within the system. It could also be sorted by unit level. It could be sorted by all tasks which were not completed or the 6 hours of the bundle period. And it could lastly be sorted by inpatient or ED based on the focus of that particular surveillance personnel. You can see there's a number of icons which are represented. The patient is identified as well as the room number and unit, the time of the alert as well as the date, whether the alert fired on the inpatient or in the ED, and there was hover over logic to state why the alert fired, whether the nursing notification form was performed, what was the pre and post lactic acid level, and it was color-coded, green for under 2, yellow for 2 to 4, and red for greater than 4. Were blood cultures performed within the time frame expected? If yes, there was hover over logic that would tell you the time and date. If no, you would receive a frown face. And then were antibiotics administered within the time frame which are on the list approved for the strategic initiative? If yes, again, hover over logic. If no, again, a frown face. This allowed for very meaningful centralized monitoring, and in many cases our facilities implemented teams to monitor these on a local level. It also enabled a centralized response that you'll see soon. An additional change was we renamed the alert. We renamed the alert in June of 2014 from the sepsis alert to the SAFE alert, and SAFE stood for sepsis and perfusion evaluation. This was based on the research study that you can see on the right-hand side of your screen, which identified that patients who triggered an alert, even in whom sepsis was not ultimately associated with their case by coding, had a 30 times higher mortality than those that never triggered it. It ranged from 5.2 to 5.8% mortality versus 0.2% for those who never triggered an alert. Well, one pushback we received when we initially publicized this was, well, this is firing in patients who are actively dying, so of course everyone who dies is listed. And it's not very helpful if it triggers 10 minutes before you expire or even a few hours before you expire. But when we looked at the data, the mean time from alert firing to death was approximately 5.3 days. So there was a significant opportunity to potentially intervene if this was a mitigable cause of morbidity or mortality. Rebranding was intended to encourage a broader diagnostic consideration than simply sepsis in these patients. So we would ask that you evaluate whether the patient has sepsis or not and treat accordingly, but if not, then is there any other cause for mitigable morbidity or mortality that I can work up and or manage? We also operationalized a second look for selected patients. A pilot was conducted in June of 2012 at 3 facilities with tele-ICU intensivists reviewing all sepsis alerts and intervening in concert with the bedside teams. This pilot was later expanded to approximately 1/2 of our patient population in June of 2014, with a preliminary analysis revealing an improvement in bundle compliance with this approach versus solely a bedside response. So, in deciding how to spread this system-wide, we leveraged the automation of lactic acid and the feedback from those tele-ICU providers who are providing this coverage, who told us that the majority of cases in whom they intervened had an elevated lactic acid level. So we changed the population to our entire system-wide population, inside and outside the ICU, in whom the automated lactic acid level returned greater than 2. Bedside providers would continue to receive the alert as the alert fired, but our tele-ICU providers would provide a second look if the lactate returned greater than 2 once those results were available. So here is the data which led us to expand this system-wide. If we looked at December of 2013 to June 2014 bundle compliance for non-ICU patients who were included in that second pilot, and compared that to the pre and the post centralized review periods, we saw a 32% increase in the patients who had successfully met the bundle criteria. The reason we identified the non-ICU patients was during the times when a patient was in the ICU and being managed by a bedside intensivist team, our tele-ICU physicians did not perform a second look. It was felt to be not terribly meaningful and possibly disruptive for a tele-intensivist to be calling bedside intensivists who are seeing the patient in real time, advocating for change in management. However, those patients who are on the floor who may subtly decompensate and kind of slip through the cracks of a robust evaluation were more likely to be those in whom we would successfully intervene. So here is some recent data with our new denominator for the last 12 months from the exact same facility that we saw the information before. Our bundle compliance, you can see, is slowly trending up, ending in May of 2018. And our sepsis mortality, although it's a little bit of a chaotic graph with seasonal variation, has trended down, ending at about 13% in this graph. Now, as you can tell, that is higher than it was in the first year of our strategic initiative, but it's a very different denominator than it was then. Then it was based on physician attestation or auto default into the denominator if 7 days post-discharge. With this particular data, it is based on post-discharge coding per the Angus criteria, which is a much smaller denominator compared to the original strategic initiative period. So what work is ongoing? Sepsis will again be a banner strategic initiative for 2019. The clinical practice is undergoing review and revision to identify any areas where we could change the standard based on the sepsis literature as well as our local experience. There is reevaluation of the CareSet or Power Plan-based alert suppression timeframes. Do we have all the appropriate entities captured? Are the timeframes ideal for that? And the development of targeted power plans for those non-sepsis clinical entities who frequently trigger safe alerts is underway. If there are patients who frequently have bowel ischemia, for example, that trigger a safe alert but are not felt to be severely septic, is there a way that we can provide decision support through a dedicated care plan to help the responding physicians manage those in a more expert manner? And that's all I have for today. Thank you very much for your time and attention.
And thank you, Dr. Simons, for that presentation and for joining us for this Davies Use Case webinar. I want to remind folks where to go find this recording and other Davies Use Case webinars and information on how to apply for Davies Awards. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. Again, that's hims.org/Davies.